I'm George Johnson. I'm your facilitator or coordinator, program chair, and I got all these jobs, and they don't pay worth a damn. However, the benefits are fantastic, and let's just take a good news moment, and I'll go first. I got good news. My PSA is 0.009. The tumor in my prostate cancer tumor in my rectum is gone, and my PSA is as low as you can go almost. And I'm taking Erlita, and that works for me. It's a new one, and anybody else on Erlita? Okay, so that's the good news. I've had this prostate cancer for 20 years, and different meds and so forth, and bouncing PSAs and Gleasons and things like that. So I just wanted you to know there's good news in this program. I got somebody else who's got good news. Bill?
I'm Bill Lewis. I spoke last month about some very unusual approaches I've been taking to my prostate cancer, and I said I was going to be getting some scans between last meeting and this meeting. I had a bone scan, an MRI of the abdomen, an MRI of the prostate, and there was no detectable cancer anywhere after having had 100 metastases and full involvement of the prostate. So I felt like that was good news too.
Thank you. Thank you. Okay, we're going to start the program, and you're familiar with it. Okay, welcome. And we're very thankful for the gift that they allow us to come in here. The SBP Discovery Institute, we just discovered some good news. And so please help us keep it clean. We have other facilities available to you. They're down the hallway here quite a bit. And so let's begin our program. Your host, you know, some of these guys are getting old.
You lead the group.
I'm setting this up for Gene. He's going to give an announcement. We're doing some succession planning. And some of these guys ought to just, you know, bag it. And I'm in there. My wife reminds me, in 5 years, you're going to be 90. Now, that is worse than saying 85, isn't it? And I've been doing this for 8 years. I do it in my sleep and so forth. But it's fun for me. But we got to get some replacement for these people. And so listen to Gene when he talks about it. Thank you. All right, newcomers, did you get a packet, a free packet? Anybody missed it, getting a free packet? Okay, there's a yellow sheet on the cover. Please fill that out. We'd like to get to know you and answer any questions, and Gene will give you a call if you want to take it. And this is our way of helping us cross-section of people. And what's our purpose? Our purpose is to help you become your own case manager. You have to manage your case. Most doctors don't think about you every day. Now, Dr. Lamb thinks about you at least once a month. Okay? Whether you go see him or not, he's still thinking about you. But the idea here is you need to support your doctor by keeping your own records. Keep a list of your questions. Hopefully, you're going to get some questions here today that you might want to ask your doctor. We don't prescribe, nor is his talk going to be about what you should do. He's going to tell you what's going on, and you might want to take a note of those and ask your doctor, how about this? And I've done that, and my doctor says, yeah, we could do that. You know, I asked him about Firmagon instead of Lupron. Yeah, we could do that. So you might get some good ideas here to ask your doctor, but keep a list of your questions in a notebook. John in the back here, he's got a notebook this thick, and he is disciplined as doctor because he pulls a tab out and he starts writing down what the doctor says and follows up and so forth. So you got to train your doctor too. But we're not a substitute for your doctor, and so you pay attention to him. And that what you hear here doesn't mean you should do it, but ask the questions. Okay, our support to you. Got a wonderful website. Our website editor is Steve. Raise your hand.
Huh? Oh, John Tassi. Website is John.
Yes. Can you see that hand? John, excuse me. You'll get even. Okay, John. And then we've got the library, and Bill Bailey. Raise your hand. Well, you guys in the back. There's Bill Bailey, and he's got a load of books out there. And one of our bestsellers is from the up in the Marina Del Rey. And this is a really great book. It's a bestseller. You can get it on eBay, or you can get it right out front. We got some wonderful DVDs of our talks. In that DVD are the charts that our doctors use. So if you want a close-up of the chart and what's that, maybe there's one or two in there that struck you. You don't have to sit here writing it down. You can buy it for $10. Newsletter. Where's our editor for the newsletter? Where are you? In the back. Oh my gosh, you guys. Steve, in the back there. Then we have Bill, who you already heard from. He helps out on that by doing a summary of the previous speakers or a speakers meeting, and that goes in there. And raise your hand. Okay. And you're going to have a lot to write this time. Outreach. This is for free if you take one of our packets of brochures on our program. And because when you wear this, people ask, what's that? And then you have a brochure or a card, you give it to them and tell them to get a PSA. Because most of your buddies are the same age as you are, and they're due for a PSA. And your son, if your son is in his 15 probably, he should have his PSA. And more importantly, because you have prostate cancer, the probabilities of his getting prostate cancer is greater. So think of your son. Nag him too. Okay. And monthly meetings, this is the last meeting of the month and of the year. Yeah, also the last meeting of the month. Don't jump ahead. I'm going to blame this on Irolita, all right? They've got some side effects they don't tell you about. All right. Now, here it is, our next meeting. Dum-da-dum. A.J. Munt. How many have visited A.J. Munt, huh? Look at that. He's the radiologist. His team will come in here in terms of different kinds of radiation. He covers them all. And he can also guide you about, maybe you're a candidate for a proton too, but seeds and all that other new stuff. So he's going to update you on in January. Don't come here next month. Well, you can come here, you won't get in, but okay. All hands, we're gonna do a countdown or a count up. And this is for the newcomers and also for Dr. Lamb. He gets a view of what you patients are up to. Raise your hand in response. How many are here for the first time? Look at that. See, we got... Good. Keep it up. Keep it up. Keep your hands up. Now, your seatmate, look at them and talk to them. And you newcomers, this is a good chance to network and ask, hey, how was that? Did it hurt? Did that biopsy hurt? When the doctor says it'll hurt a little, they can tell you how little, all right? How many have been recently diagnosed Cancer, okay. How many have had prostate cancer for up to 1 year? Okay. Now we're going to count up to 4 years, raise your hand. And now we're going to do 5 to 10 years. Look, see, is that the peak of the distribution here? Let's go 11 to 15 years. Yeah, I guess that was it. And now we're going on the downslope. Higher than 15 years. See, look at you newcomers. Look at that. I got 20. And where's Jack? Are you here today, Jack? Okay. How many? Bob?
26 years.
26.
19.
19.
17.
Okay. All right. So this stuff works. Keep coming back. It works if you work it. Okay, let's talk about Gleason scores. This is a very important measure. How many know your Gleason? All right. Now, let's do a countdown for you, Dr. Lambs. Let's see what our profile is on that. A grade 6, that's a 3 plus 3. Raise your hand. How many? Okay. See how important that is. You are real prime candidates for active surveillance. They don't need maybe a scalpel on you now. Okay, a low 7, which is a 3 plus 4, is okay, they're about an equal number. And then a high 7, a 4 plus 3. All right, about an equal number. And now an 8. How many 8s? Okay, a 9. I got a 9. All right, we got a good number of 9s. Anybody got a 10? Okay, we don't allow 10s in here. That's why I'm. Where's the 10? Oh, how you doing? How you doing? You keep coming back. We can't get it lower, but stay in there. Okay, let's do a treatment survey for the newcomers who are not sure what to do, or for Dr. Lamb, how we're changed here now. How many have not had any treatment but are on active surveillance? Raise your hand. See how many we got doing that now? All right, that doesn't mean you just sit home and wait. No, you're active. You get a PSA. You see your doctor. Surgery of all kinds, prostate surgery. All right, the so-called golden. All right, let's do radiation of all kinds. Here we got a few more. Look at over there, a lot of those. See, I got radiation. Now we have over here Gene. He's had everything. Well, quite. Almost everything he can remember. So how many are on seeds? I'm interested in seeds. How many had brachytherapy? Wow. How many do we see here? 1? That's interesting. Okay, on ADT, hormone therapy, it's called. There are a lot of us are on that. Look at the. And how many are on Lupron? Raise your hand. Look at that. What to say? That's basically ADT to you means Lupron. I'm on Firmagon. These things have side effects. Firmagon really stands for firm is gone. I warned you. All right. Chemotherapy. See, we got chemotherapy, and that's being expanded and improved. How many are on the new treatments, like, I was going to say, Zytiga, Xtandi. What else you on?
All of the above.
Yes, he's on everything.
Lutetium.
Say that loud.
Lutetium.
Okay, you had that.
In process.
In process where? Down the street?
No, Sydney, Australia.
Sydney, Australia. Speak to him why he's doing that. Okay. Recurrence. How many have had recurrence? That's the story of prostate cancer for many of us, okay, recurrence. So that's why you got to keep up to date, and that's why he's here. Undecided what to do, raise your hand. Okay, and maybe you'll find something here that you want to ask your doctor about. We need your support. Not canes, we need financial support. And so volunteers, pass those baskets, please. And move those baskets down the whole row, you know, just like you used to do in church, okay? And I tell you what, our break-even point is $10. So we don't want to dip into our reserve too far. They're tax exempt, so you want to offload that extra money you got, so when April 15th comes around, you won't have regrets. We're not affiliated with any medical or religious organization. Well, now, while that basket's being passed, let me remind you, we have 6 basic steps. Early detection, get a PSA early. You want to have an early detection or you want a too late detection? Do it early. High definition diagnostics. The new diagnostics have greatly improved. They can find the cancer very well. And then targeted biopsy. That means they're aiming for the tumor, not just the random one. Now, the random is very prevalent down here in San Diego, not elsewhere. We're going to have later or early next year, Dr. Cooper, who does targeted biopsy. He has an MRI and ultrasound, and he puts that needle right where the tumor is rather than where he thinks it might be. So we recommend you have that done, because then you're going to know your Gleason score and be able to decide what to do. And maybe do active surveillance. And treatment selection is very important. This is a targeted biopsy. It's a reminder. This is a reminder moment. And the oncology branch of the National Cancer Institute survey of the doctors, 83.6% of respondents believe MRI targeted biopsy to be moderately to extremely beneficial in the evaluation of prostate cancer. So if you want to know, if you're going to have treatment, you want to know where it is in the prostate. You'll know it's in the prostate, but where in the prostate? Okay, today's agenda, and I'm going to have Gene, after he counts the money. That's going to take a long time for him to count the money, I hope. Okay. Gene's going to introduce our speaker. Let me make a comment about my speaker. I might have a conflict of interest because he's my doctor, too. And how many have visited Dr. Lamb? This is an alumni association, huh? No dudes, okay? Now, he's up in Marina Del Rey. Now, a lot of you guys say, oh, I don't want to go up to Marina Del Rey. You do. But what I do, because I need a monthly shot, I don't go up there every month to get it. I get it down here with Dr. Dato. But every 3 months, I go see Dr. Lamb. So they're somewhat in cahoots together, and I get full coverage as a result. Think about it. Okay.
This is what we want to talk about. George mentioned it briefly. It's time for us to really get serious about replacing some of us. I'll soon be 80. Lyle is not far behind me. George has already talked about how old he is, approaching dirt. And Lyle couldn't make it today. Lyle spends a lot of time in Baja, and he emailed me last night, and he says, there's no way I can get through the checkpoint now what's happening down there. So he may be a permanent resident down there now. But anyhow, I tried to define basically what each of us do. And Lyle's been at this for 18 years. Actually, he took over as the meetings were being held in a kitchen in Spring Valley. And then I came in a little after that. So this kind of tells you the background, and it gives you our phone numbers. So what I tried to do is let you know what the functions are, so you can help us out for any or part of what it is that needs to be done. We understand this is not going to happen in a minute or an hour or a month, perhaps, but we need to start getting some people involved that will handle the situation for us. So put some thought into it if you could help. And that right there, there's a printout out there on the table if you'd like to pick one up to see all the definitions of what needs to be done here. So because we've really, no question about it, I don't know if Dr. Lamb can verify this or not, probably we are the largest support group in the state of California, qualified as independent from any medical or religious groups. So we're very proud of that. On our member listing, we've got 850 members in my member list. That's a lot of people, and that's how many get our newsletter distribution every month and so forth. So anyhow, we've got a very active group, and we don't want to lose track as we start to move forward here. Anyhow, enough of that. The next main thing is to introduce a guy that I started seeing 11 years ago, thank God, because I'm still looking at you. And he's a patient, he's a doctor to many of us here. So he's a UCLA grad, did all of his education at UCLA, and he's the research director of Prostate Oncology Group up in Marina del Rey. And as George mentioned briefly, that drive up to Marina del Rey is well worth the time to get up there and see these guys, because they're experts in our disease, and they don't go beyond our disease. So thank you very much. Here's Richard Lamb. Come ahead. Let me find you.
Okay, good morning. Let me see if this works here. Testing. Okay, perfect. Okay. So today I'm going to talk about, we're trying to devise a new user-friendly staging system for patients, and we're calling this the 5 Shades of Blue. You may have heard of it at the PCRI conference. Instead of calling patients and their cancers low risk, medium risk, high risk, relapse, metastatic disease, we're just trying to help patients identify what they are by just picking the color that best represents their situation. So we'll go over the 5 stages of blue today, and we will also review some new treatments that look very promising for 2018 moving forward. So I've been doing this for 17 years. I've done maybe 1,000 prostate exams per year. So after 17,000 prostate exams, I quit. So no more. So this represents my feeling whenever patients ask me, do I have to do a prostate exam? So that's, I've had enough. Okay. All right, so why is being knowledgeable of your stage important? Because it helps you understand your own particular situation, how serious it is, if at all. Because prostate cancer is not just one treatment, one disease with one treatment. There's so many different facets. One of the National Institute, or one of the guideline setting groups, calculated that there's about 2,000 possibilities of treatments or formulas or pathways of treatment because there are just so many different types of variables. So we want to help patients pick the pathway for themselves that's the best. The advantage of the 5 different stages that we try to help people identify would be that they don't have to be overwhelmed by all the treatments. They could pick the treatment or follow the pathway that best suits them. And it's based on, and all the treatments would be based specifically on that stage, and it's all more based on factual studies and less confusion. It's also a good way for patients to interact with their doctors knowing exactly what type of stage they're in. So why is it so hard to get good treatment from a patient perspective? Number one, doctors and primary care physicians and patients themselves, they have misconceptions about prostate cancer. Some people think, oh, it's no big deal, everyone has it, it's not serious. Some patients actually overreact and get terrified. Their life stops the minute they're told they have cancer. And this is a different cancer than most cancers where life does go on. There's still a long life ahead of you, even though you've been diagnosed with cancer. The typical doctor that the patient sees in the beginning usually does one treatment only. And then when he does consultations, the patient sees various doctors who do their own thing. So there's going to be a lot of conflicting advice there. And then at the end of the day, patients are told to, well, here are all your options, make your own decision. And so it becomes very overwhelming. This information overload, of course. And then on top of that, what makes it more complex is the staging system that's very complex. And then more of a objective or the goal of this color staging system is to help patients truly estimate their risk of microscopic metastases. And that's really how you determine what type of treatment you should get. And hopefully, after you know your stage, you get a perspective of what situation you're truly in. Okay. So let's first of all define cancer for that matter. Cancer is a clonal disease, meaning cells that all are very similar and they all have a potential, and let me underline potential for spreading. And so when the cancer is spread within the mothership, the prostate, then there's a chance that the cancers eventually could go elsewhere. And sometimes when we tell patients you have cancer, prostate cancer in the bone or prostate cancer in the liver, that is different than, let's say, having bone cancer or having liver cancer. It's also important that we're going to go over the concept of micrometastases, so cancer you don't see. So how does cancer or metastases actually hurt you? How does it shorten one's life? Well, when it gets big enough and severe enough, it damages your organs, it damages your bones, it could cause fractures, it could cause severe anemia, it could weaken your immune system, it could cause liver disease, it could block off your kidneys. So there's lots of potential baddies that could happen with visible cancer that has spread from the prostate. And that's what, of course, makes it dangerous. So these are some pictures of metastatic disease. So this is a nuclear bone scan showing that there's cancer within the bones, these little black spots here. And so obviously, believe it or not, a lot of these patients don't even feel it. So you could have this and not feel it. But if you feel it, it might present as right leg pain when you're walking, or back pain when you lay down and it doesn't go away, you just can't get comfortable. Back pain that goes away with just readjusting, that's usually not cancer. Okay, so cancer pain is usually just kind of a chronic, unremitting type of discomfort. This is an example of cancer within the liver. And, these could cause nausea, this could cause pain in this area, in the right side. Occasionally, someone goes in and say, oh, I'm yellow, and that's because the cancer within the liver has blocked off the bile duct. So this is cancer in the liver. This is when you feel it. This is a PET scan showing, various areas of metastases, just another example. So it's important to think of prostate cancer as almost like two cancers. One is how did that happen? Okay, so one is cancer within the mothership. So this is the prostate. So if you get rid of the mothership, you should cure the cancer. The other situation where the cancer is systemic. It's no longer localized. It's more metastatic and spread. And we're going to go over the concept of systemic disease that you see and systemic disease that you don't see. And that's the most important concept in terms of when you decide how to treat the prostate is what are the odds that you have invisible cancer outside the prostate? So the concept of invisible microscopic disease is obviously not as serious. If you can't see it, it can't be that bad, right? And if you can't see it, I tell patients, if you can't see the disease, it's not going to hurt you. It's not going to cause symptoms. And if you can't see it, then you can only determine if you have it by taking an estimation, an educated guess. And that's where knowing about the mothership, the cancer in your prostate, will help us estimate what are the odds that you have invisible disease. So if you have invisible disease outside your prostate, therefore, if you get rid of the prostate, you're not done. So that means the cancer will, people say, come back. But it's not actually that the cancer came back, it was never gone in the first place. So I tell patients, your cure rate is actually, let's say, 100% minus the likelihood you have invisible cancer outside the mothership. So if I tell you, oh, I think you have about a 20% chance that there's invisible stuff outside your prostate, your cure rate when we treat your prostate is 100 minus 20. Does that make sense? And we're assuming that we're 100% successful in getting rid of the mothership. Usually with modern day treatments, we're actually looking at about 95%. So getting rid of the mothership is actually not as much of a challenge as addressing and getting rid of the invisible stuff. And so sometimes if you have a high enough likelihood of invisible cancer, then not only do you want to get rid of the mothership, you want to do some whole body systemic treatment to decrease or maybe get rid of the invisible stuff that's outside the mothership. Okay.
Biopsies cause invisible cancer?
No. So we're using this color system where we can basically, if a patient is able to define his color, he should be able to get an estimate of his likelihood of having invisible disease outside the prostate. And once you know your color, then you know your situation, then you could make a better educated decision. So the 5 colors are sky, teal, azure, indigo, and royal. So there are 5 shades of blue. Sky is what we call low-risk cancer, cancer that's Gleason 6 only, a low PSA, less than 10, either no nodules or at worst a tiny nodule on exam, and usually very few number of cores, and we'll go into that in a bit. Teal is the modern, another way of describing intermediate risk prostate cancer. And that's usually Gleason 7 disease, PSA higher, or with a PSA higher than 10, less than 20. And there's a larger nodule on prostate exam. Azure is the high-risk prostate cancer, and that's where the PSA is greater than 20. Gleason score is 8, 9, or 10. There's a large nodule on exam. There's a palpable seminal vesicle invasion. So that's where there's even a higher risk of the microscopic disease. So basically, Sky is low likelihood of microscopic disease. Teal is intermediate likelihood of microscopic disease. Azure is high likelihood of microscopic disease. So these are the guys who show up for the first time with the prostate cancer, and they're trying to decide how to treat the prostate cancer, assuming it hasn't visibly metastasized. If it's visibly metastasized, you automatically jump to the royal section, okay? And when you're at royal, typically the cure rate is very, very low, and the goal is primarily to contain this cancer for a long time. Right between royal and the first three curative treatments is this category called Indigo. And Indigo prostate cancer is prostate cancer that's been treated, the mothership has been treated, and yet the cancer came back, or the cancer was never completely gone. So that's relapsed prostate cancer. But there's no visible disease yet. So Indigo is you can't see metastatic disease. It's just invisible disease, PSA is going up, we don't know where it is, it doesn't hurt, it just makes us nervous, okay? So these are some questions that one could ask based on, if you ask your doctor or you ask yourself what my PSA is, for example, what my highest Gleason score is, what the doctor felt on exam, what the scans show, if you've had previous surgery or radiation, and is the PSA rising on treatment or off treatment. Once you answer these questions, you'll be able to help identify your own shade. So you could also find this, do this online on this website. You could also get this book by Dr. Scholes, which also goes over the different shades and the treatments for each shade. So prior to jumping into each stage, the first step in the diagnosis of prostate cancer or the investigation of prostate cancer is the dreaded biopsy. And traditionally, the dreaded biopsy is what we call a random 12 to 14 core sampling of the prostate. So if you imagine this is the prostate, the urologist will take 12 to 14 samples kind of in a systematic grid. So they go 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4. So they're not really looking for a spot. They're just kind of throwing out a net and seeing if they catch the cancer. So for the ladies in the room, imagine if I said, oh, your breast cancer blood test was abnormal. I would like to sample each breast 12 times. Or for anybody in the room, while we're doing a colonoscopy, why don't we just poke around throughout the colon and just throw the net out and see if we catch cancer, okay? So, but everyone's going to say, well, let's find the polyp in the colonoscopy. Let's find the lesion on the mammogram. Why are we just randomly doing this? Well, that's how they do it. So, and that's how they've been doing this for about 40 years. And so in the last 3 to 4 years, there's a whole slew of data that is finally maturing to, that's finally, this logical approach is why don't we take a picture of the prostate, and if we see a spot, then we biopsy it. Okay? If we don't see a spot, well, if we can't see it, it can't be that bad, right? Okay, so let's not randomly biopsy people. Let's just find a spot and then sample it, okay? So finally, there's enough data to randomize good studies to generate some enthusiasm. And finally, this paper was published in the New England Journal of Medicine about 8 months ago. And they basically so they took 500 men, everyone who presented with a abnormal PSA, and took the study coordinators put half of these men into the group that just went through the random biopsy. And then the other half, they did an MRI first, and then if they saw a spot, then they did 4 cores. So 12 to 14 cores versus 4 cores. Okay, a lot more logical. Okay, so here's the data. The men who had the MRI, 34% of the men were diagnosed with prostate cancer, which we categorize as significant cancer that needs to be addressed. Okay? And 9% were diagnosed with the insignificant color category sky low-risk prostate cancers. And they basically found that 28% of the men had clear MRIs and they didn't need a biopsy. Okay. You contrast that with the other half of the men who had the 12-core random biopsy throughout the net, 12 cores, and there were less diagnoses of the significant cancers, only 26% as opposed to 34%. So in other words, it doesn't mean that this group had less significant cancer. It just means that this approach had a lower likelihood of detecting the significant cancers. So MRIs were better at finding the important ones. Also, this may or may not be a good thing. The random biopsies found all these cancers that never need a treatment, the insignificant cancers. And insignificant cancers, the only ramification is you're told you have cancer, and if you're not too informed, your life is ruined. Oh, I'm a cancer patient. Oh, I better get my affairs in order. So having an insignificant cancer is almost a negative. And of course, by randomly biopsying, we found a lot of these, okay? And during these biopsies, if you can imagine logically, the more samples you take, the more complications. Double the chance of blood in the urine, double the chance of blood in the semen, double the chance of pain, almost double the chance of bleeding in the rectum, a little bit higher risk of impotence. Okay. So biopsies cause impotence. People forget that. And biopsies cause impotence, not permanent, but up to 6 months. Okay. So now that we have the MRI as a kind of a proof of concept that imaging is a good way to stratify whether or not a patient needs a biopsy or not. Let me point out that in England, what they're doing now is before they even biopsy you, they do an MRI first and then determine if you need a biopsy. Okay. So the Brits are a little bit more forward in this approach. But honestly, MRIs are not perfect. If they don't see it, it doesn't guarantee there's no cancer or significant cancer. So it turns out that you do miss some cancers, but random biopsies miss cancers too. Okay, so MRIs miss cancers but miss less than random biopsies. So how do we kind of be more sure that there's nothing going on when we tell a patient, oh, the MRI looks good, don't worry about a biopsy? Well, it'd be nice if we had ultrasound corroboration. So if the ultrasound doesn't show anything, that's also a reassuring sign. Now we have all these urinary genetic tests that will also help us, and these 3 are called exosome, select MDX, and PCA3. This one, in my opinion, is lower it's not as good. So I currently like these 2 urinary tests to help me decide if a patient needs a biopsy in the beginning. It also helps me determine if a person needs a follow-up biopsy if he's on active surveillance. Okay. There's also a blood-based test called the 4K score, and that will also help us stratify who needs a biopsy or not. So I tell patients if everything here looks favorable and strongly suggests to me there's not clinically significant prostate cancer, I would say there's at least a 90 to 95% chance you don't need a biopsy. And, and then if they say, hey, I want to guarantee that you catch my prostate cancer, then I'm going to say, well, even if you did a random and focused biopsy, it's not guaranteed. There's no guarantees. If you want a guarantee, I got to take out your prostate, and then I'll look, So So you got to accept some degree of uncertainty, and that's the definition of life, right? So let's go into the different categories of prostate cancer. Let's start with the lowest risk category, and that's called the SKY category. And just to refresh your memory, the color group SKY is Gleason 6, no or tiny nodule, and a PSA less than 10. And within the SKY category, I'm just going to separate it into low, basic, and high. Low is the classic Epstein criteria. Only 2 or 3 out of 12 cores with cancer. The cores have to be less than 50% involved. And in other words, low quantity and good quality cancers. So slow growing cancers and a small amount of cancer. Okay. The high SKY cancers, they have a higher PSA density, meaning PSA to gland volume ratio, and they have more disease, but the disease is still the slow growing type. Okay. So all in all, these are still the favorable risk prostate cancers. And how do we manage these patients? Well, I would say for the mostly low-risk patients, I think active surveillance is the smartest thing to embark on because these are the cancers that have very low risk of spread, low risk of causing problems. They grow very slowly. And if we could spare a patient 5, 10, 15 years of treatment toxicities, I think that's a good risk-benefit ratio. It's a good trade-off. If you have a lot of cancer but only Gleason 6 and everyone's nervous, then this is the time to consider some of these focal therapies that are officially still experimental, considered experimental because we don't have a long follow-through period. But I do know that focal therapy works very well. It depends on the type. It could be as high as 80% success rate at getting rid of the cancer. And why focal therapy and not the whole gland? Remember, we want to minimize side effects. So if we're going to treat somebody begrudgingly because this is a SKY patient, we might as well do as little damage as possible. So some sort of focal therapy could be considered. Okay. The next category of blue is the Teal category, and that's the intermediate risk prostate cancer. These are the guys who have Gleason 7 disease, their PSA is, or the PSA is between 10 and 20. The nodule is bigger on exam. Nowadays, the nodule is bigger on ultrasound and MRI. Okay, so we're not just relying on the digital rectal exam to quantify the volume of cancer. So I separate these into the low Teal, so the favorable, intermediate risk, and the high Teal, and all the stuff in between. So the low Teal is you only have a few cores. The amount of Gleason 4 is less than 20%. The high Teal is you're having more Gleason 4, like 60, 70% Gleason 4, which puts you into the 4+3 category. There's more cores involved. The ultrasound or MRI shows a larger lesion. So that would be the high Teal, okay? And this is kind of everything in between, okay? So even for low Teal patients, we could consider active surveillance or focal therapy. Basic Teal patients we're recommending that, well, this is serious enough to justify treatment, which could cause side effects. So we still want to pick the one treatment that has the least side effects. And at this point, you're going to get a pretty good bang for your buck with seed implants and what we call hypofractionated radiation therapy. And you guys could ask Dr. Munt more about that in January, but I'll go over the new data on hypofractionated radiation therapy. We went over it last year a little bit as well, but we'll give you some updated information in the next slides. The high Teal patients are the patients that are closer to the Azure stage, meaning they're high-risk intermediate type prostate cancers. They do need a little bit more treatment. So they need either external beam radiation therapy. You might throw in some seeds as a combination. You might even need 4 to 6 months of testosterone blocking. And surgery is still an option in this situation. So, as mentioned earlier, I'm going to talk a little bit about the hypofractionated IMRT. Basically, hypofractionated IMRT is you're giving a higher dose of treatment, but you're giving it over a shorter period and less number of radiation visits. So the olden days, they used to do radiation over 8.5 weeks, and you get a little dose every day. And now they've been doing a higher dose over 6 weeks, even a higher dose over 4 weeks, and now even a higher dose over 2.5 weeks. So the first good data that came out about hypofractionated radiation therapy was what I talked about last year, was 4 weeks was equivalent to 8 weeks. So in terms of effectiveness, success rate, side effects, and definitely easier on the calendar. The scheduling is a lot easier for the patient, way more convenient. Okay. This year, just last month, they actually found Dr. Hoffman and her group, they actually followed up these patients for 5 years, and they found that the relapse rate for this shorter course treatment was actually lower. So 10 versus 15%. So not only was it equivalent, but it might even be better than the 8.5 weeks treatment. Okay. So that's the first time this has been reported. I have a feeling that there's, after all is said and done, when you add up all the studies, it's going to be equivalent. But this one study at least shows it could even be better. Okay. Again, presented, in fact, a couple weeks ago. This is a 9-year study of 5 visits over 2 weeks, done at a New York facility. So you got to take this with a little bit of grain of salt, because this was a 9-year, a single institution study. Okay, and they found that the 5 visits at 9 years, if you have low risk prostate cancer, your cure rate was 93%. Okay, with 5 visits, very convenient. If you have intermediate Teal grade prostate cancer, your cure rate's 81%. UCLA is up to about 5 years now. They're doing their 5-visit, what we call SBRT, hyperfractionated treatment, and their early data looks comparable to this New York facility. So this may be the new way to go, which is 5 visits over 2.5 weeks. So let's now move on to the group, the subgroup Azure, which is the higher risk, higher likelihood of invisible metastatic disease. These are the guys who have Gleason 8, 9, and 10. Their PSA is usually higher than 20. There's a large nodule on exam. Oftentimes you could see it breaking through the capsule, invading the seminal vesicle. And it's important to remember, because you guys hear the capsule a lot, and you guys hear that, oh, it's broken through the capsule. Breaking through the capsule does not mean that it's going to metastasize for sure, okay? So only about 50% of men whose cancer breaks through the capsule actually metastasize. So it's not the end of the world if the capsule's broken, okay? Conversely, even if the cancer is within the prostate and it hasn't broken through the capsule, a lot of patients go, phew, it hasn't left the prostate yet, I am good, That's not true either. The cancer could escape the prostate even if it hasn't broken through the capsule. So it's not a black and white thing. In the capsule you're safe, out the capsule you're doomed. It's not like that. So it's just a matter of degree. So of course, usually if it's in the capsule, it's probably not going to escape. And if it's broken through the capsule, it doesn't necessarily have to escape, okay? So, but in general, if it's broken through the capsule, you're in the Azure category because there's a higher chance it has escaped. And in this situation, not only do you want to address the mothership, but because there's a higher risk that's somewhere out here, you have to incorporate some systemic therapy. And these are various types of Azure, low Azure, high Azure. It's just a matter of degree, but typically if you have Gleason 9 or 10, PSA's 40, lots of, a big lump, you could see the cancer in the seminal vesicle. These are the high Azure people, okay? People who have a little bit of Gleason 8, it's not broken through the capsule, the PSA is still small, but the only bad thing about the situation is the Gleason score. You're actually low Azure. So in this case, the risk of spreading is 30 to 40%. In this case, the risk of spreading could be 60, 70%. So that's, and then depending on the grade of Azure, you change the degree, how you treat the situation. So basically for the low Azure group, because there's not a super high risk of metastatic disease, you could get away with treating the mothership with a combination of seeds and radiation and a shorter course of androgen deprivation, 4 to 6 months. If you have a high risk of spread, like 60, 70%, even though you don't see the spread, but you think it's out there, then you have to not only treat the prostate, you want to radiate the pelvis, because if it left, there's a good chance it's in this first level here. And you want to do a much longer course of androgen deprivation, and you might even need to add Zytiga. And this is everything in between. So the difference between low Azure and high Azure is basically the duration of hormone therapy, the addition of Zytiga, and the addition of radiation to the pelvis. Okay. So these are the three color stages that you're still going for cure. And this is some new data published in the journal JAMA just a few months ago on the 7.5-year survival likelihood of or prostate cancer survival, not dying of prostate cancer, of the three various approaches. So if you did surgery, there was a 83% chance prostate cancer has not killed you, okay, after 7.5 years. Okay. If you do radiation plus hormones, and the average duration was about 20 months, it's also about 82%. So very similar survival likelihood with these two approaches. And that's why we often say oh, the outcome's about the same. It's just pick your poison, surgery or radiation. But this was very interesting in that if you added the seeds on top of radiation and you do 12 months of hormone therapy, there's even a higher risk that prostate cancer doesn't get you, 90%. So, and I talked a little bit about this type of data last year as well. The combination seems to be leading to the best outcomes. So what about Indigo? Indigo, just to refresh your memory, is relapse prostate cancer. Most of the time it's either only in the prostate or your PSA is rising and you don't know where it is, okay? And there's no visible systemic metastases, so there's nothing in the bones, lymph nodes, or other organs. So this is the type that patients don't feel it other than the anxiety one sees with the PSA rising. So we're going to break it down to three different levels of Indigo. Basically, the low Indigo is clear-cut, invisible disease, and we still think there's still something within the prostate area. Okay. The high Indigo is, we know that there's something in the lymph nodes above the prostate area. And basic is, we think it's there, but and eventually it's going to get further out if we don't address it. So these are the three levels. So for low Indigo, which you think it's only in the prostate fossa, prostate bed, after surgery, you could do radiation just to the prostate area. And based on some new data that I'm going to go over that in a second, we might even radiate the pelvis as well. And now there's good data to support using some hormone blockade in addition to radiation to the prostate bed. Okay. If you've had radiation therapy and we think there's prostate cancer within the prostate area, then you could still do something to that area, and it could involve either freezing the prostate area. You could either do HIFU, which is heat, basically, or you could go back and do surgery in rare cases. Okay. Again, these are guys where we think it's still there, there's nothing invisible out here. Let's give it a go to go for cure one more time, okay, at the mothership, okay? Or if the PSA is going up very slowly, all these treatments sound too scary or too many side effects, and the PSA is going up slowly, maybe just leave it alone. You know, we went for cure, it didn't work. I'm not sure I want to do it again, so let's just watch it. Okay, and that's one extreme situation. Or if you don't want to go for cure again, nor do you want to watch it, you could do periodic androgen deprivation to block or prevent the cancer from growing. Okay. So the high indigo cases where we know there's prostate cancer, probably in the prostate area, and we're sure that there's cancer in the pelvic lymph nodes. And if we still want to go for cure, now we got to be more aggressive. So we have to treat the radiation to the prostate bed and the lymph nodes, and of course, or you could do the freezing and surgery and whatnot. But in addition to retreating the local area, you for sure need some systemic therapy to mop up the probable microscopic disease. So we would add hormone therapy for sure for at least 12 months. We would add Zytiga for 12 months. And if there's a lot of cancer within this pelvis, we might even add 4 to 6 cycles of chemotherapy. And this situation, as dire as it might sound, you're still curable. Okay, we're talking about 30 to 40% chance, but it's a big price to pay if you still want to go for cure. Okay, or you don't want to watch these cancers because they're high indigo. Don't forget. So these cancers, if you don't go for cure, you definitely need to start hormone therapy. Okay, so the last shade of blue is royal. Okay, royal is basically metastatic. In general, royal is metastatic disease, distant metastatic disease, and it is you could have on Lupron or without or androgen deprivation. Anytime there's visible metastatic disease, you're considered royal. Okay. The only exception that puts you into the royal category that you don't see metastatic disease is when you have a rising PSA and you're already on hormone therapy. So that's what we call stage D0 castrate-resistant disease. But you don't see it yet. But if you do nothing, you're going to see the cancer sooner rather than later. Okay, so this would fall into the low royal category. But these are all royals. Okay. So the low royal group, meaning you don't see prostate cancer yet, but the cancer is already castrate resistant, you can use these two new medicines, Erleada and Xtandi. And I'm going to go over the data that was released this spring right now. So the first slide is the data presented in February on Erleada. Basically, for men in this category, if you take Erleada, you're going to delay the development of visible metastatic disease by about 2 years. So what they did was a very large study of 1,200 men, and 800 of these men were given Erleada, and 400 were given placebo. And in the placebo group, about a little over a year later, cancer was visible. Okay. Okay. One other caveat is invisible cancer, you're not going to feel it, right? Oftentimes, even when you see the cancer, you're not going to feel it. And it could take another year before you feel the cancer, even if you see it. So it is scary, but it's not. There is always a little bit of time before there is some time. It's not an emergency. Okay, but the patients that took Erleada, it took 3 years and 4 months before visible cancer came up. So it delayed the development of visible cancer by about 2 years. Okay, so in other words, it works, but the price to pay is some people get tired, or a lot of people get tired, but these are severe side effects, severe fatigue, about 1 out of 150 men. Rash happened in about 4% of men, and really bad hypertension in 1 out of 50 men. And to a milder degree, a lot of men got mild rash, mild fatigue, mild hypertension. Okay. And again, this is for people without visible cancer. And these insurance companies are very strict about approving these drugs, paying for them, because this study was only done with people without visible cancer. A couple months later, Xtandi, their same competitive study came out. Basically, the two drugs are very similar, and essentially their outcomes were similar as well. Same type of study, invisible castrate-resistant prostate cancer. Almost the same number of men studied, and the delay in development of visible cancer went from 15 months to 37 months. Okay, so basically, I'm going to say Xtandi and Erleada have the same objective, practical benefit, okay, in delaying visible metastases. Slightly different side effect profile. Severe fatigue seemed higher, 4%. Severe hypertension seemed higher, 5%. There's a 1 out of 200 chance of a seizure in this study. And they've also noted that there was a 10% chance of a fall or a fracture with Xtandi. So effectiveness is equal, but perhaps there were more side effects. And I'm saying perhaps because these drugs weren't compared head to head. Okay, but in my experience using Xtandi in more advanced cases, it does seem to have severe side effects in about 10% of men. Okay, so let's talk about the basic royal patients who have visible metastatic disease and who present with visible metastatic disease, and they haven't been on androgen deprivation yet. So, and these are men who don't have a lot of cancer yet. So, for example, one little spot here, or on this PET scan, one little spot here, on this bone scan, one spot here in the neck. Okay, so this is low volume metastatic disease, and for patients who haven't had hormone therapy before. Okay, so in the past we would say, oh, let's put everyone on Lupron and call it a day. We can't cure you. This is metastatic, incurable, and when Lupron stops working, we'll do something else. When something else stops working, we'll just react to it. Okay. It turns out that if you add Zytiga to hormone therapy in the beginning, you're going to have a better outcome. You're going to live longer. Don't wait till hormone therapy stops working before you add Zytiga. Okay. Now there's some studies suggesting that zapping those occasional spots or the mothership will further improve your outcome. If anything, I can't say that zapping it will improve everyone's survival, but one practical benefit I've learned over the years is you get to stop Lupron sooner, and there's a longer period before you need to go back on androgen deprivation therapy. So there's some advantage to this. And the reason why we're accepting this approach, this kind of cherry-picking approach, is the ability to deliver radiation to these spots is becoming better and better. So we're not harming patients, and we might help patients. So that's why we're adding spot radiation to active areas. If you have low volume of metastatic disease despite androgen deprivation, meaning castrate-resistant prostate cancer, then you would now add Provenge, immunotherapy, which has a good benefit for low-volume castrate-resistant prostate cancer. We also then start either Zytiga or Xtandi, and we still would consider zapping those sites. What about extensive disease? High royal. Okay, so you can imagine it'd be kind of silly to zap every little spot here, right? You'll keep the radiation doctor in business, but you're also going to fry up the bone marrow. So you really don't want to do whole body radiation here. Okay, so this now you have to resort to whatever works on the whole body. Okay, and traditionally, if you are newly diagnosed and you haven't had androgen deprivation, we usually add hormone therapy plus chemo as the first line. If I think the patient might not be able to tolerate chemo, I would just do Zytiga with hormone therapy. If I think the patient could tolerate both, I would do chemo plus hormone therapy, and then afterwards do Zytiga. And this is all based on, the combos here are based on good studies. I think I talked about them last year, improving survival. Okay. If you have widespread disease despite hormone therapy, castrate resistance, then you're already on Lupron, so then you add either Zytiga or Xtandi, and then you do these sequentially, either radiopharmaceuticals such as radium-223, lutetium, chemotherapy, and immunotherapy. Okay. So a little bit of update on new treatments for castrate-resistant high royal prostate cancer. On lutetium has been talked about a lot. It's a radiopharmaceutical that we administer, inject. It goes into the body, goes where the cancer is, and it releases radiation to the cancer, kind of like a smart bomb. And UCLA experience, I was just updated, they're saying they're getting about 40 to 50% success rate. This is an example of a patient of mine who had a PSA of 30-something, 36, and he had Zytiga and Xtandi and stopped working, and he had a smattering of spots, about 10 spots, a couple here, one here, one here. So he had about 10 spots and a whole clump of lymph nodes here. You see that? So after 3 treatments, $30,000 later, his PSA dropped to about 8, and everything disappeared. So no more lymph nodes, all the little specks are gone. Okay. So he's a happy camper. Okay. This is the data released from the Australians. Maybe one patient is included in this group, our patient who went to Sydney. This was released a month or two, actually 6 months ago, and these are what we call waterfall graphs, and these are PSA behavior of 30 men who got treated with LU-177. So all the blue lines are the PSA has dropped more than 50%. And so a lot of people responded. In fact, 17 of 30 men, their PSA dropped more than 50%. And another, 8 men or so had a PSA drop of less than 50%. And there were 17 men where they were able to they did a pre and post scan, and 14 of the 17 men had this type of reaction. So That's good. So it's very promising. The company that owns this drug, Endocyte, just got bought out by maybe Bristol Myers or Novartis for $2 billion. Yeah. So the stock went from $5 to $25 in 1 year. Yeah. So it's promising. Okay. And this is, and we're proud to say that we've sent a lot of guys to UCLA, Australia, Germany, to get this treatment. Update on Keytruda. I talked a little bit about it last year. This was a larger study called the Keynote 199 study. A lot of these guys were heavily pretreated, over 200 men. Almost all of them had chemo, Xtandi, Zytiga. Most of them didn't have that many options. So unfortunately, the response rate in terms of PSA was about 11%. Okay. So not that great. Only about 6% of these men, we could see a change in scans. About 17% of these men, everything was stable. So for end-stage advanced disease, these are the types of responses we're getting with Keytruda. Perhaps using Keytruda earlier, when a patient is less ill, his immune system's probably better. The Keytruda should work better. And we're getting a hint of that in our experience. You know, we're getting maybe 15, 20% PSA drops, 20% PSA stable. But I think more importantly, it's going to be finding the right patients that benefit rather than just giving it to anybody. Okay, so we got to tailor or select the patients who we think will benefit. We might even need to pair it up with other immunotherapies. Bristol Myers, they're going to release their preliminary data, I think late next year, on a combination immunotherapy, Opdivo and Yervoy. So we're looking at that with excitement. I think this ultimately, combo will probably be better than a single agent. Okay, and we see that in a couple other diseases as well, such as melanoma. Okay. This is immunotherapy. Olaparib. Olaparib is what we call a PARP inhibitor pill that we talked about about 3 years ago that looked really promising for select men who have either inherited genetic defects or their cancer has certain genetic defects. And in New England Journal of Medicine, the success rate was at least 60% with this pill. We have some follow-up data released a few months ago. One was using olaparib in conjunction with abiraterone. And again, these are men who are advanced cases. They've had chemo already, so they're pretty sick. And they randomized these people into olaparib plus abiraterone versus abiraterone alone. Abiraterone is Zytiga, by the way. And they found that the combination seemed to delay progressive disease by about 6 months. Okay. So combo is better than single agent in this heavily pretreated group. More side effects though, more heart issues, more anemia. So it's not, it does have side effects. Okay. This is a cousin of olaparib called rucaparib, and this was data released just a couple weeks ago. And they call this the Triton study. They only took people who have the BRCA1, BRCA2 mutations. So either inherited BRCA1, BRCA2, or the cancer itself had BRCA1, BRCA2 mutations. And they got about, in the visible cancer, 25 men with visible cancer, almost half of the men, cancer shrunk. Okay, so that's pretty good. And in the 45 men that they studied, a little over half, 23 of the 45 men, their PSA dropped more than 50%. So I think there will be a role of these PARP inhibitors in the next few years. Okay. So just to kind of go back to the importance of staging, The goal of the staging is to identify the patients, and so patients can have a tailored treatment that they can talk with their doctors. And hopefully, keep, as George said, you're going to get more out of your doctor when you're educated, and you're going to make the doctor think a little bit more. And this is a good way to test out your doctor to see if he's worthy of your life. So sometimes these doctors are so set in their old ways, they're not keeping up. So you could keep up and keep your doctors in check by knowing your color stage. Okay. So again, this is a very good book that Dr. Scholes and I wrote that will help you guys get knowledgeable. So at the end of the day, knowledge is power. All right, so we have plenty of time for questions.
You want to get your chair?
Yes.
Okay, what we're going to do, we're going to scan the audience. We'll start here and move down here, and then we'll come back and so forth. So here's the game we play. One, you got to ask a question, not tell a story, and say it very clearly. And then over here, Dr. Lamb will repeat the question, or that part of the question you choose to answer, so we have it on our DVD. See? And okay, you had your hand up first.
Dr. Lamb, good morning, sir.
Good morning.
Can you say a few words about the difference between proton beam therapy and fractionated radiation? Which one is preferable? And which is more expensive?
Let me make sure. You guys still hear me, right? The question is basically proton beam therapy versus fractionated. So all radiation therapy is fractionated. So you're giving it over multiple doses. I wonder what happened. Even higher. Testing. Okay, I'll just hold it. Okay, so proton beam therapy is another way of delivering radiation to the prostate. There's some purported theoretical advantages. The beam is deposited in the prostate and it doesn't touch the other organs. It's, I think, maybe 3 to 4 times more expensive. But it turns out that traditional radiation is so effective now and low side effects, there isn't really a difference in long-term side effects or effectiveness. So for something that's so much more expensive, that's not giving any practical benefit, I'm leaning towards typically just traditional radiation therapy. And Dr. Munt will expand upon that in January. Yeah.
Okay, any other questions? Okay.
I was wondering if you could give some insight for the younger patients, if you know of a study for the younger men with the aggressive prostate cancer, any treatments that have proven effective for them versus, exhausting themselves to die at a young age anyway.
So the question is younger patients, what to do with younger patients who have aggressive prostate cancer. Well, you got to put in perspective, younger patients have a lot more years to live, so you want to, you can't just say, oh, I'll just keep you alive for 20 years and, because younger patient can live another 40 years. So you want to tend to be more aggressive. And if you have aggressive cancer, there's a high risk, there's invisible stuff out here. So you want to knock down the prostate cancer in the prostate and do systemic therapy. Just because you're younger, there isn't a special treatment only for younger people. So you look under. Basically, the principles in Azure would be, Azure, color stage Azure would still apply to a younger person.
Any more here? Okay, switching over here. In the back.
In the basic royal, you talked about a combination of ADT and radiation. Do you start those treatments at the same time as my first question? My second question is, when or what's the indicator you pull them off of the ADT? And then, is there any studies that back up this that I could take to my doctor and say, you need to think out of the box?
So the cornerstone of Royal is androgen deprivation therapy. So you start that first. Think of the radiation to the metastatic lesions as a bonus. And I would try to do the bonus within 6 months. Okay. So you don't have to do it simultaneously. In terms of our goals of treatment is we want to get the PSA down to 0.10 or less. That's a good goal. And at that point, you have enough ammo to talk to your doctor to stop treatment. Okay. So the more metastatic disease you have, the more likely no one wants to stop treatment. But if you only have a couple spots and you zap them, I think it's fair to stop treatment, because we know that when you have relapse cancer and it's relapse cancer testing. If you have relapse cancer, then if you don't see the cancer, you may do intermittent treatment. But if you see it, you typically don't. But if you only have 1 or 2 that you're going to zap, I think it's very safe to do intermittent.
Okay, another question? Yes.
When would you normally start recommending chemotherapy when you know the cancer's back and you're on Zytiga and Lupron and all that?
Okay, so question is the role of chemotherapy in relapsed cancer. So basically there's, typically we use chemo only in the royal color stage. And if you have relapse cancer and you have metastatic disease and you haven't had hormone therapy before, you would actually consider using hormone therapy plus chemo right up front. Okay. Another scenario, let's say you've already had hormone therapy and the cancer is progressing and you've gone through Zytiga, for example, then chemo is it's coming up. You may squeeze in some Xtandi beforehand, or you may just jump into chemo. So a lot of relapse castrate-resistant metastatic disease is sequencing everything. Ideally, you do all the treatments, don't miss out on any of the treatments to stay alive. And so a lot of the science and art of this situation is, when to use what in what sequence.
In the back.
Hi, I'd like to get clarification about one of the criteria for the unfavorable Teal high. Usually I see 50% or more positive cores of any Gleason score, 6 or above, is considered one of the factors, but it sounds like you're saying only count them if they're 7 or above.
Correct. Yep. So high number of cores or a lot of cores, a lot of cancer, but all low grade is, in our book, sky.
Great, thank you.
And I think people will catch on. So yeah, we're learning that pure 6, 1 out of 1,000 cases, if that, will metastasize. So you can really treat it like a sky. Oh, and just to kind of placate everyone, if you have high sky, that's when you might do something low impact like brachytherapy or focal therapy, experimental therapy, laser, 2CAD, stuff like that.
Dr. Teal, I noticed that in high Teal, that was the only time I saw surgery as a treatment option. Why is that?
Part of it is you want to leave. It's so low teal is brachytherapy. Really is a good approach with very minimal side effects. And for high teal, there's a little bit of, I think the data will mature, but surgery still has a role in versus brachytherapy in high teal, basically. So, but it is, you run the risk of needing radiation afterwards, and there's more side effects to surgery. But I don't want to completely block out surgery as an option.
Okay. All right, sir. Dr. Lamb, are there any hard and fast guidelines on how long with royal stage ADT plus Zytiga you stay on it? Once it's below detectable, how long would you stay on it? If you did go intermittent, how long would you stay intermittent? You look for a PSA to rise to a certain level before you start back again?
So the question is for royal patients, how long you're on Zytiga plus androgen deprivation. If you have moderate to high volume royal disease, then you almost have to stay on it indefinitely. Never stop, because at around 3 years or so, it's going to become resistant. It will resist. If you, again, like one gentleman back there, if you only have 1 or 2 spots, I think it's fair to consider stopping after about a year. And the couple guidelines would be get the PSA down to 0.1, zap those couple spots. If you tolerate it well, I might stretch it out to 15, 18 months. If you're not tolerating it well, I would stop it at 12 months. You want to start it, of course, let's say the PSA goes from 0.1 to 0.2, you're not going to immediately start. You know it's going to go up, so you got to expect that. So there isn't a specific number, but it's the number that I think new spots will develop. And it could be as high as 5, 6, or as low as 1 or 2.
Okay, let me ask you, how many think you're in royal flu? How many think you're in royal flu? Okay, who got?
Is genomic testing improving for providing guidance for selecting treatments?
Question is genomic testing. Oh yeah, for sure it's improving. And we use a lot of genomic treatment to help us decide if a patient needs treatment or not. So that might be a tiebreaker. If we're thinking, oh, this guy is a sky or low teal, we're considering active surveillance. But if the genetics of the cancer point to a potentially more aggressive variant, then we may either be more vigilant or we may recommend treatment, especially in the low teal patients. There's also men who have inherited genetic abnormalities, such as BRCA1, BRCA2, and those patients tend to be higher risk, and we tend to have a lower threshold to treat those men.
Question, is there any research going on to delay the process of conversion of castrate sensitive to castrate resistant?
So what can we do to delay castrate resistance? That's a big question. At this point, it's Zytiga. That's a proven treatment to delay castrate resistance. Use it before castrate resistance, and you'll delay castrate resistance. Chemotherapy does that as well in the high royal group. That's why people live longer in the chartered study when they took chemo versus chemo plus ADT versus ADT alone. Chemo did delay castrate resistance. Maybe SBRT, zapping the hot spots, might delay castrate resistance. That we don't know yet. There was an interesting study that just came out for if you have relapse metastatic disease and you give ADT, and if you zap the prostate area, if there's known cancer there, that may have delayed castrate resistance, which is very surprising. So that data came up pretty recently as part of the STAMPEDE trial. So basically debulking, knock down more cancer cells before there's less cancer cells to mutate. Okay. All right.
What does the pathologic stage classification T3B mean?
So pathologic stage is what the biopsy or the surgical removal T3B. So T3 is outside the prostate. Okay. So T3B is outside the prostate in the seminal vesicle. Right. So what that means is if it's in the seminal vesicle, there's a higher risk that there's invisible stuff. Doesn't mean it for sure, but turns out that if it's invaded the seminal vesicle, there's a 50% chance in general that one will relapse. In other words, there's a 50% chance you didn't get it all.
The question, this is probably more for the guys down in the sky category. Is there significant benefit to having biopsy if your 3T MRI already shows that there is a visible lesion?
So the question is role of biopsy in an MRI lesion. Well, was that lesion ever biopsied?
No.
Okay. So the initial criteria for giving someone a sky is based on a random biopsy?
There was TERT, and that tissue was biopsied, and 3-3 was distinguished from that. The latest opinion is that that particular cancer was in the central region, and the cancer that's causing my PSA to be high is not in that region.
So I guess the main question is there a need to biopsy a spot on MRI? That would be kind of a general question. Yeah, you don't have to biopsy every spot. So one is if the spot is growing, so sequentially there's changes. If the spot is large, if the spot is very near or kind of breaking through the capsule, those would be reasons to preemptively biopsy to find out what's going on. Okay. I would biopsy. You know, if something is sitting in the neurovascular bundle, and all you know is you had Gleason 6, but things could be worse than that, you don't want to put your head in the sand. Yeah, you definitely want a focal biopsy.
So then 3 targeted versus 12 random, or putting them both together?
I would say 3 targeted, yeah. Yeah.
All right, let's switch over here and we'll come back.
I've been in active surveillance for about 8 years, and actually I'm one of your patients. As over time, my PSA has gone up a little bit, still under 10, or it's about 8, but my Gleason score has gone through the biopsies at the NIH from 6 to 7, now they're saying 8, which I know when I go back there, they're going to try to force me or try to talk me into surgery. Which is going to have less side effects, the radiation or surgery?
So your situation is a low Azure, and of course, number one, if you have low Azure, you do need treatment. It's time to not do active surveillance anymore because the risk of invisible microscopic spread is going up. So you want to kind of nip this in the bud. In terms of treatment, you know, every treatment has its own side effects, but in general, the radiation approaches will have less side effects, equal or maybe even better outcomes. So I would lean towards the radiation approaches.
That's including sexual side effects?
Including sexual side effects. There's a better chance you'll retain sexual function if you did radiation.
You seem to mention Zytiga a lot more than Xtandi, particularly in the early use area. Is there a reason for that? Have you found particularly good results with Zytiga and less so with Xtandi?
So the question is, why Zytiga, basically? Right. So first of all, there's certain scenarios where there's only data for Zytiga. So therefore, I'm only going to recommend that. I think that scenario is newly diagnosed, never had hormone therapy, and you have metastatic disease. Good, strong data from the Stampede trial using Zytiga and androgen deprivation. So that's a slam dunk. Xtandi will come out with data as well. It's just, and then, yeah, not yet. And then the other scenario is when you have castrate-resistant disease, meaning the cancer is progressing despite androgen deprivation, then officially there's actually no right answer. If you ask 100 oncologists, actually everyone would say, I don't know which one to use first. Okay, but the consensus is Xtandi seems to be a little bit tougher to tolerate, more cognitive and fatigue. The caveat is if you're on Zytiga, if you have diabetes and you have congestive heart failure and you can retain fluid, or prednisone is not a good thing for you, you would do Xtandi before Zytiga. Okay. Again, the goal is you're going to get all of them sequentially. Yeah.
Okay, over down there. So given a Gleason score of 6, under what conditions would you advise going into treatment, radiation or surgery?
So if you have a lot of 6, high volume 6, and you're nervous, and we think there's some 7 hiding in there, and if we don't want to investigate, then I think treatment is a fair game. And the younger you are, the more likely doctors will be scared to do active surveillance. But if the more confident we are that all you have is 6, the less likely we're going to push you into treatment. Whatever we see on ultrasound or MRI, if we feel a large nodule, if the lesion's greater than 15 millimeters, 20 millimeters, 25 millimeters.
And if there's no evidence of lesion in MRI?
Yeah, if you don't see anything on MRI, assuming it's done well, then there's probably no iceberg in there. There is just a tip. There's no tip of the iceberg. So you probably don't have high volume. Then yeah, it'd be a perfect situation to do to do active surveillance.
Okay, the woman against the wall?
Yeah, I have a question. If you're in the royal stage and you have ADT and chemo, and a year's gone by, you're still on ADT, your chemo situation passed, that was an 18-week scenario. PSA went down to 0.18, but now it's rising to say 0.4 something. At what point would you take a look at Zytiga or something other than just the ADT? I have 2 questions, that's one.
So the summary is early castrate resistance after androgen deprivation and history of Taxotere. So you don't do chemo again. So you would, first of all, I'd probably do some staging scans to reassure us that there's not that much cancer. And I'd probably get in the Provenge while your hubby's strong and his immune system's robust. That takes 5 weeks, one and done. And then during that period, the PSA will probably keep drifting up. And then shortly after that, you add Xtandi or Zytiga. So you don't have to let things go crazy before you add it. I would tend to add it on the early side.
And then my second question, you were talking about zapping things. I ran across an article on focused laser ablation. This is regarding a tumor that's extended from the prostate into the bladder. Have you heard of the FLA? I don't think it's done everywhere.
Yes, so I talked about that last year, so it's on the DVD, but it's very early, it's for early stage traditionally, and that's not what I would do. I would avoid laser in that situation. Yeah.
At what stage would you check BRCA1 and BRCA2?
So if you have a lot of family history of prostate cancer, if you have Gleason 8, 9, or 10, if you relapsed, if you have metastatic disease, if you have if you have a couple sisters with breast cancer, I would check it. And the test is only $100 now, so even if your insurance doesn't pay for it, just get it checked. Oh, the BRCA, BRCA mutation. It's an inherited gene defect.
Back when robotic surgery was very, very popular, the word was that the doctor that did it made a big difference on whether you were going to have a good result or not. And when we look at seeds, how important is the center or the doctor? How important is that if you're going to choose seeds?
It's just as important. You want someone who's done a lot, who has good follow-up. Yeah, it's just as important.
Is there a consumer report?
Not really, no. It's your first person you could ask is your oncologist, your radiation doctor. You could look up PubMed, see if they published. So that's a good way.
Starting and stopping ADT, does that help to prevent it becoming castrate resistant?
Does intermittent therapy delay castrate resistance? No. No. So 15 years ago, we thought intermittent, not only is it great because you get treatment holidays, you're also going to develop castrate resistance later. It turns out that the castrate resistance develops at around the same time. So, but the advantage is you still get treatment holidays.
What is that time?
Yes. If a person's had prostate cancer for, say, 18, 19 years and has had some imaging done, like bone scans and stuff like that, and it's invisible, and you can't do an MRI because of the pacemaker defibrillator, what's the next best imaging?
So the question is, what's a good imaging to look for relapsed or look for cancer, systemic cancer in the face of a rising PSA? All these new age PET scans are probably better than MRIs. So the one that's covered by Medicare is Aximin, and your PSA should be probably at least 2.0 for it to be sensitive. The Dr. Almeida in Arizona, he does a carbon-11 PET scan. That's very good and sensitive. You could probably go at a PSA of 0.8, 0.9. Gallium-68 PSMA PET scans are done at UCSF and UCLA. Part of an experimental protocol. You could detect cancer as low as 0.5. So UCLA and UCSF, yep. The out-of-pocket cost could be anywhere between $1,000 to $3,000. Yep. And then the last but not least, the Mayo Clinic, they have their own carbon-11 only in Rochester, Minnesota. And that's, if you're Medicare, it's less than $1,000, and that's very good. Yep.
What is the 4K blood test? How is it expressed, and how does that inform you?
So 4K is, it's basically, I call it a super PSA. So it's total PSA, free PSA, pro PSA, and kallikrein. So there's 4 chemicals, enzymes. And with various levels of those enzymes, you generate a 4K. Each of those is a K. So it generates a score. And the higher the score, the higher likelihood you have what we call clinically significant prostate cancer. The lower the score,
Score expressed.
I think it's just 0 to 100. Yeah.
Okay, time for 2 questions. One, Wayne about this.
George, you mentioned Erlita. What is Erlita compared to the other therapies you mentioned?
So Erlita was for low royal. So it's in one of the slides. It is for people who have rising PSA despite Lupron or Firmagon, but you don't see any visible cancer. So, and then you use it with ADT to delay seeing something. It's basically holding cancer at bay for an extra 2 years. You stay on it.
If a remote holiday and PSA starts up again, you add to this.
So when you're on holiday and your PSA goes up, you just go back on the prior treatment. Usually Lupron alone. Yeah. In that situation, you might add Zytiga, you might zap the spot. Yeah.
Sure.
Last question. I have a real basic question. What does or could it mean if your PSA keeps going up gradually over a period of years, say from 4 to 8 or 9 or 10, but yet every time you have a biopsy done, it shows a 6 and it's constant after several biopsies, that your Gleason score isn't changing even though your PSA keeps rising gradually?
So the question is what to do if your PSA is rising and your repeat biopsies keep telling you it's 6. So there's a couple factors. One is the prostate could be growing. That could contribute to the PSA going up. Gleason 6 cancers do grow, so they could make the PSA go up. It's just the advantage of Gleason 6 is they don't spread. Okay. The third issue is did you do a random biopsy and did they miss the Gleason 7 that's on the back of your prostate or front of your prostate? Targeted. It was a targeted? Yes. Okay, so maybe the Gleason 6 cancer is growing, which it's okay.